Thank you so much for joining us. I'd like to welcome everyone to the second installment of the Society of Thoracic Surgeons and the Society of Cardiovascular Anesthesiologists webinar series, Across the Drapes. Today's webinar is titled Across the Drapes, Multidisciplinary Management in Mitral Valve Repair. Please note, this webinar is being recorded and will be available on both the STS and SCA websites and STS YouTube channel. At this time, I am pleased to introduce our moderators for this evening, Drs. Gina Lingana and Dr. Shubha Chatterjee. Dr. Lingana, let me turn it over to you.
Thank you so much. Welcome everyone to our webinar tonight. We are so excited to have you for our second installment of Across the Drapes, and today we're going to talk about mitral valve repair. I would like to introduce my co-moderator for this evening, Dr. Shubha Chatterjee from Baylor, and our behind-the-scenes moderator, Dr. Avinash D'Souza from Northwell. Dr. D'Souza will be monitoring the Q&A, so if you have a question that you'd like our panelists to answer, please put it in the Q&A and he will do that. Additionally, we will have a poll tonight just to gather more information about who our audience is tonight. Now I'll turn it over to my co-moderator, Dr. Chatterjee, to introduce our panel.
Great. Thanks, Dr. Lingana. So it's my pleasure to introduce our speakers representing two premier institutions. First, from New York Presbyterian Weill Cornell Medical School, Dr. Stephanie Mick, who is a cardiovascular surgeon, associate professor of surgery, and the surgical director of the minimally invasive and robotic cardiac surgery program. And her colleague, Dr. Megan Fitzgerald, who's the chief of cardiovascular anesthesiology at Cornell. Their colleagues today are from the University of Pennsylvania. That is Dr. Pavan Lurie, who's the professor of surgery and is now transitioned to Jefferson University, and Dr. Jared Feynman, who is an associate professor of surgery and the vice chair of education in the Department of Anesthesiology. So welcome to everyone, and with that, we'll begin with our case. Great. So here we have a 65-year-old lady who presents with worsening palpitations, shortness of breath, and chest tightness consistent with class 2, class 3 NYHA symptoms. Her preoperative transthoracic echocardiogram demonstrates normal LV systolic function with bileaflet mitral valve prolapse, a myxomatous valve, severe mitral regurgitation, moderate tricuspid regurgitation, and mild pulmonary hypertension. She has a preoperative transesophageal echo that shows a small PFO, 65% LVEF, mitral valve prolapse of the posterior leaflet with severe mitral regurgitation. She had a cardiac catheterization that revealed no coronary artery disease, and she presents for consideration of mitral valve repair versus replacement. So with that, we'd like to bring in our colleagues. And Echo first.
So here we're going to present a intraoperative transesophageal echo. So for those of us who are a little less familiar with this is a 4-chamber view, and you can see that the flail mitral valve leaflet. And then here is another view. Of the same valve. Here's that same valve with color on, so you can see the eccentric regurgitation. And here we go, we see that anterior directed jet again. So with that, I'm going to stop sharing, and I'm going to ask the first question to Dr. Jared Feynman. Our first question is, our surgical colleagues tell us that they would like to do this mitral valve repair or replacement minimally invasively. You are planning to extubate the patient in the operating room, consistent with a lot of the data on minimally invasive mitral valve surgery. What preoperative considerations are you taking into to make that decision, and how does this influence your anesthetic plan?
Sure. So first, in terms of the decision of whether this patient is a good candidate to extubate in the operating room, we want to see, what they have going on in the way of comorbidities. So this woman obviously has the significant mitral regurgitation and symptoms resultant of that, but she doesn't seem to have a lot else going on in the way of, significant pulmonary disease that would make me concerned about extubating her in the operating room. She's not an extremely morbidly obese patient where I might worry about extubating them and having them lay supine in the operating room for a period of time. Her cardiac function is relatively normal, again, which would lead me towards somebody who's probably okay to extubate in the operating room after this procedure. So, as long as this is something that we can do, minimally invasively, and she doesn't have any comorbidities that didn't come up on the pre-op evaluation that you went through, I think she's probably a good candidate for, fast track extubation or extubation in the operating room.
Awesome. Thank you so much. Dr. Fitzgerald, I know that Cornell has been very successful in extubating these patients in the operating room. Can you talk a little bit about your anesthetic plan, whether that includes regional techniques or what your anesthetic plan would be for this patient, if that is your goal?
Well, I think first the goal is always reasonable to have that in mind that you plan to extubate the patient in the operating room. That's almost our default. And then if things come up, such as prolonged complicated repairs or any other unexpected patient circumstances, then we may discuss again whether or not we want to change our plan. But for the most part, the default is to extubate in the OR, and we prepare for that by doing the paravertebral blocks. Our regional team performs them in the holding area before they come to the operating room with some sedation. And then in the operating room, our intraoperative management will include minimal narcotics, so maybe 5 to 7 mics per kilo of fentanyl for the case. And we'll dose IV Tylenol if it's been long enough since their preoperative PO Tylenol dosing. So multimodal analgesia, and if the patient had any anxiety or anything, that would make them a good candidate to add dexmedetomidine doses as we're waking them up as well. All of those things help. But I do think it's important to emphasize that we want to pick the right patient, the right surgery, and the right circumstances to extubate, and make sure we're doing it thoughtfully every time.
Great. Let me shift to Dr. Atluri and then to Dr. Mick. Your patient comes, they say they want something minimally invasive or they want something robotic. How do you approach that? Specifically, who are the candidates who are appropriate for the minimally invasive, and who are patients who say might not be appropriate candidates?
Yeah, I mean, I think anybody that presents by default, we consider for minimally invasive, and it's really looking for contraindications. The real big contraindications that really stand out are really bad peripheral vascular disease, lots of atheroma throughout the aorta. Those are really the big ones. I will tell you, in terms of, I know in the early days of MIS, there was lots of trepidation on tackling very challenging valves, et cetera, but I think we've gotten over that learning curve, and I'm sure Stephanie will tell you, I think we're just as comfortable repairing very complex valves as straightforward valves by either approach, right? Sternotomy versus minimally invasive approaches. So there's a few others, really severe MAC. Often I will not do MIS. Really bad endocarditis, especially if it's up by the anterior leaflet, by the trigones, because you really don't know what kind of Pandora's box you're going to be getting into, is another one that stands out.
Okay. Dr. Mick?
Yeah, I mean, pretty much, I agree with Pavan. Everyone is, in my mind, a minimally invasive candidate until proven otherwise. And so it really amounts to a focused screening algorithm. I get a CTA, chest, abdomen, pelvis, looking for aortic atheroma. I look for the size of the femoral vessels to make sure that they're appropriate for cannulation peripherally. Any kind of anomalies, discontinuous SVC, you're trying to look for anything that might hamper your surgery. And then obviously everybody needs coronary imaging. If somebody has multivessel coronary disease, that's not going to be a good candidate for an isolated mitral valve repair, which is what essentially minimally invasive surgery amounts to most of the time. Moderate AI used to be a contraindication, or more than mild AI used to be a contraindication before the retrograde cannula was back on the market. But thankfully that is back on the market now. So mild up to moderate, but not more than moderate, because then you're looking at, needing to intervene upon the aortic valve. That would be another big call out. But, tricuspid regurgitation, complexity of valve disease, of the mitral really doesn't really play into my algorithm.
I think the real important thing to remember is the benefits are short-term. There's cosmetic benefits and then there's short-term benefits, right? And I think they're wonderful benefits as long as you don't jeopardize long-term outcomes, either with complications, detriment to myocardial function, et cetera. And as long as that's the case, I think it's really a wonderful benefit that we can afford patients.
Absolutely. And what I tell patients is your first priority is a successful operation. The second priority is minimal invasiveness. And so in my mind, the whole screening algorithm is to make sure that you're offering the patient the same risk surgery, or at least the same risk surgery as a conventional approach. Anytime I feel slightly that I am increasing their risk by doing it robotically, then in my mind, that is a complete no-go, because that's putting the cart before the horse.
Right.
Can
And
you
then-
expand on that, Stephanie? Like who meets that criteria? Who's the patient that you think minimally invasive will put them into
So,
a higher
like
risk category?
somebody who has an EF of like 30%, 25%, because the cross clamp times are a little bit longer in robotic surgery, then I'm taking an already struggling heart and subjecting them to more risk by having increased cross clamp times. Or somebody who, that would be one of the biggest ones, somebody who comes in with compromised cardiac function. Recently, I told a patient who had a kidney transplant that I thought we should avoid. He had just had a rejection episode. His creatinine was like 1.8-ish. And I told him that I thought that we may be jeopardizing that transplant with, with a longer cardiopulmonary bypass time. There are things like that.
You made one really important point, Stephanie, which I loved, which is that you think about it from the patient and what's best and then put the approach on. One thing that does worry me is if you look at these large data sets is, I think part of that also includes being able to repair the valve, right? First and foremost, when we're talking about in 2025, we really should be repairing valves that should be repaired. Unfortunately, there's a lot of data sets when you look at all comers, small volume centers, high volume centers, et cetera. The proportion of valve repairs gets skewed towards replacement, and that always worries me. So surgeons need to remember it is fine to repair a valve by sternotomy, and don't give up on the repair for the approach.
I think it's really important when we talk about repairing the valve. So Dr. Fitzgerald, can you talk a little bit more about what you're looking for on TEE to really advise and guide our surgical colleagues if this valve is repairable or not, and what you're looking for, or what stands out for you as, hey, this might be a problem. We actually might need to replace this valve today.
Yeah, well, I think that I can't answer if it's repairable, but I can provide all the information I can to make an informed decision. So what I do my best to do is to don't look at lose the forest for the trees, and make sure we look at everything, rule out that there is no other valve lesion. And so assuming that there's no other reason not to proceed minimally invasive, what am I going to look at for the valve? I do a really thorough assessment in 2D first, because it almost doesn't matter what the 3D says if the structure isn't matching the functional consequence. So what direction is the jet going in? And I really want to understand that with color on, so that I can put it together with my 3D assessment. I also am on high alert for clefts, which the cleft is an absence of a structure, right? So those are hard to see, sometimes the hardest. And so if I have a jet that doesn't match any of the prolapse or restriction and the associated jets, then I'll be looking a little bit closer and where that's coming from. And then to inform their decision are things like the ventricular size and risk for SAM. So we'll look at the anterior and posterior lengths, the C-sep distance, and the angle of the mitral annulus to the aortic annulus. And so in general, what I understand, and I'm sure Stephanie can expand more on this, is conceptually, is the coaptation point closer to the LVOT or further away from the LVOT? And does it look reasonable that they can pull the coaptation point posteriorly as a part of their mechanism for repair or not? So those are the kinds of things I try to provide.
No, thank you so much. Dr. Feynman, anything kind of to add or echo about what Dr. Fitzgerald had to say?
Sure. Yeah. I mean, I think she covered, most of the important points. One thing, I don't know if we have any trainees, anesthesia trainees on the meeting or not, but one thing that I want to emphasize that she brought up was it's always important, and this is one of the first things that I go through with our fellows when I'm giving them the lecture on mitral valve repair, is that you have to make sure that your jet matches what you're expecting to see, right? So if somebody's coming in being billed as P2 flail, and you start looking at your jet and you have an anteriorly directed jet, but then another, say, posteriorly directed jet that you're seeing somewhere, you need to investigate that further and figure out what's going on and why you're seeing that jet. And it could be due to any number of reasons that may affect the repair that the surgeon is going to do. So that's something you need to look at from the beginning. Another thing I'm always on the lookout for, areas of calcification on the leaflets, significant amount of MAC, Pavan already mentioned it, but we always want to make sure the surgeons are aware if there's a lot of either leaflet calcification that may make the repair hard to accomplish, or if there's a lot of MAC that can put the patient at risk for some of the complications that we can see, devastating complications that we can see after mitral valve repair.
How about, Dr. Feynman, how about you put the PA catheter in and the PAs are in the 80s with a systemic pressure of 110? How does that modify your anesthetic management, and then even for the surgeons, if you do that, if you see that, any other considerations?
Sure. So, I want to look and see what the other hemodynamics look like and what the rest of the heart function looks like. A lot of the significant increase in PA pressures that we see in these patients is due to the mitral regurgitation, which should hopefully be gone or largely gone by the time the surgery is done. So I want to look at the right ventricle. Is there right ventricular hypertrophy that says that maybe this is longer standing? Is the right ventricle significantly dilated? Is there a decrement in right ventricular function? If I see any of those things, then I may have a higher suspicion that we're going to need a little more inotropic support coming off, or maybe even an inhaled vasodilator, something like nitric oxide or Flolan. I wouldn't start any of those before the repair is accomplished because it's just going to make your mitral regurgitation worse and put the patient at risk for some pulmonary edema. But they may be necessary post-bypass once the mitral valve has been repaired.
Okay. Dr. Mick, any other considerations when you encounter severe pulmonary hypertension going in terms of preoperative planning or approach?
I mean, hopefully I'm not going to be surprised with PA pressures in the 80s by the time I get to the OR. This is part of why I do such a very careful preoperative assessment. I can tell you, I didn't mention this before, but if I have a patient with very severe pulmonary hypertension, that might also give me pause and not do a minimally invasive approach for the same exact reason that I said before. It's longer pump runs, longer cross clamp, more tenuous situation. And so I think part of my goal as a surgeon is to be finding out as little as possible new information in the operating room as possible. I just wanted to expand a little bit on what Megan said about, I know we're backtracking a little bit, but we had a great case very early on after I joined at Cornell, a patient who had endocarditis in the past, and we thought she had some ruptured cords to the anterior leaflet. And Megan was there and she was studying the echo, and she's like, I think I see another jet. There's another jet that doesn't make sense. There's another jet that doesn't make sense. But basically what we found was that the patient had anterior leaflet flail, but also a perforation, which didn't change the approach of the surgery, but it was so helpful for me to have that information as I was getting ready to do the case, knowing that the echo had been completely scoured and we knew all the pathology, because that's the whole point. That's why you're looking for clefts. That's why you're looking for all those things, so that when we go in, we know exactly what we're tackling.
Great.
Yeah, thank you so much. I think that's like an important point, and kind of why Shiva and I kind of started this webinar series, is to emphasize the collaboration between our teams and how we can both help each other have the best outcomes for the patient. So really thank you so much for sharing that story with us. Dr. Lori, is there any other information before, like Dr. Mick alluded to, before she makes the repair, any other information that kind of hasn't been mentioned before you go in and get on bypass that you'd want to have? Pavan, you're muted.
Yeah, I was just gonna say, I think thinking about it more holistically, that pre-operative intra-op echo is critical, because it's a real-time study. I think, Jared, you are able to provide such great data up front, that oftentimes we need to sometimes just corroborate what we see in the TE that we might see in the office. But then it's those little surprises, right? That second jet, the small jet that may be coming from the commissure, the clefts that may be resulting in jets. Is there prolapse to an anterior leaflet when we may not appreciate it to begin with? What is the SAM risk? That's the other really big one, right? What's the LVOT look like? And we've all been fooled more than once when we think, oh yeah, there's very little SAM risk, and then you go ahead and you do the repair. Next thing you know, you've got SAM to deal with, right? So all that stuff I think is very, very important. Ventricular function is one that I think is underappreciated and important to appreciate up front, especially as you're coming off bypass. If there's wall motion abnormalities, if the LV function is 30% to start with, that's another critical one. Just looking at our own data set, in those patients that have an EF less than 60%, what we notice is a quarter of those patients will come off with abnormal ventricular function. So to know, is that expected or is it not expected, is also important.
Right.
Yeah, there's lots of critical information that is provided, and I like to spend a lot of time with my cardiac anesthesiologist in the operating room going through the study in detail. I think that's a really valuable exercise for surgeons and anesthesiologists.
Dr. Mick, moderate tricuspid regurgitation, how do you decide whether to address it at the same time or choose to, leave it be?
I typically go by the preoperative transthoracic echo. So I try to repeat their transthoracic echo within a week or so of the surgery. And if there is moderate or more regurgitation, I will repair that. If the patient has then, mild on the transesophageal echo, I try not to use that information, because that's false information. The times I'm more aggressive, so like even if it's just mild TR, would be times when the patient has underlying atrial fibrillation that I'm doing an ablation for. Because as you all know, atrial fibrillation in itself is a cause of tricuspid regurgitations, and not everybody is going to have a perfect result from their maze. So if the patient I'm pretty aggressive in the setting of even mild tricuspid regurgitation. If a patient has atrial fibrillation, like long-standing persistent atrial fibrillation, in my mind, that is itself in a risk factor for progression of TR, and then I'm very aggressive. If a patient has mild TR preoperatively on their TTE and their RV isn't dilated, then I'm not as aggressive under those circumstances. But basically the bottom line is you really need to make sure that you go by the preoperative assessment. On the other hand, if they had mild on pre-op TTE and then they have moderate in the OR, then I will say, oh, well, we for sure have to repair this.
So that's a full mitral tricuspid repair, biatrial maze, and a left atrial appendage procedure?
If the patient has AFib, yes.
Great. Excellent. Dr. Lurie, how do you approach atrial fibrillation, concomitant AFib in your patients?
Yeah, I mean, everybody gets an MIS clip that I put right through the sinus, and we're able to, if it's minimally invasive, I will put the clip on, but by going underneath the aorta, and you can lift up on the aorta under low flow states and put the clip on. Sternotomy, pretty standard, right? You put the clip on. I do a full endocardial maze on all patients on the left side, and on the right side, I usually do for permanents.
Okay.
The tricuspid, my tricuspid criteria, all severe tricuspid regurgitation gets managed. Tricuspid valves that are greater than 4 centimeters, I will think very hard about taking care of, especially if they've got concomitant TR. The part that gets difficult is when it's a dilated annulus and there's very little tricuspid regurgitation, which thankfully is not a very common occurrence. And of course, the other big criteria you really need to think about is there true pathology to the valve? Ruptured cords should be taken care of because that's only going to get worse, and also leads that may be impinging leaflets.
Great.
I think we're recognizing more and more the importance of managing tricuspid regurgitation, and also the importance of the fact that just because you take care of the mitral valve, the tricuspid regurgitation is not going to improve on its own, and rather could result in progression of disease.
Right.
So better management.
There are flexible rings, they're rigid, semi-rigid, complete, etc. Is this all kind of much ado about nothing, or do you really try to tailor your approach based upon the characteristics?
I mean, when it comes to the mitral valve, I think I've got a fairly scientific approach to whether I'm using a complete ring versus a partial, posterior band, rigid versus flexible. I am not so tailored to the tricuspid. I just haven't seen great data sets. I guess I feel like rigid is better. I don't have data to say that it's better. I certainly think it's better than a De Vega suture because I think the recurrence rates have been higher on that. Now, shy of that, whether you use a flexible versus a complete, I don't know any great data in that regard. I don't know if Stephanie does.
Stephanie, Nick, for the mitral position, in terms of how do you approach in terms of what you're using based on the pathology?
Oh, are you talking about mitral or tricuspid?
Mitral, sorry.
Oh, yeah, I've got a huge.
Whatever you want.
Yeah, for that, I've actually got an algorithm of type 1, so annular dilatation. I always do a downsized annuloplasty, complete ring, rigid. Anterior leaflet pathology, I do complete rings, rigid. All other type 2s, based upon our paper that was published in, God, was it 2018 in the EJCTS, when we looked at our patient population of like 8,000 cases. And we saw an increased risk of pacemaker placement with a roughly 1% higher rate of pacemaker placement with complete rings. And so based upon that, I usually put in a posterior band. If they've got any degree of aortic insufficiency, if they're left dominant, I tend to use a flexible band. Just what I do.
Can you summarize for this side of the drape, what are the benefits and of each, and what are the major disadvantages? Obviously pacemaker, but why?
Yeah, I mean, I think it has to do with the AV node, which is just anterior to the posterior medial trigone. And so I think that one extra stitch that comes up and around up by A1 is the issue there. And at least that was our hypothesis in that paper. And I think if we, as long as you make sure that you get the trigones appropriately and anchor the ring in fibrous tissue, then I think a posterior band is fine. I think that's where some surgeons can shy away from the posterior bands. The data is very good on posterior bands as long as you don't get dehiscence. When I need to reapproximate the AP dimension of a valve, so functionals, or with like ischemic MR, like the type 3Bs, then you want to make sure that you decrease the AP dimension, especially with ischemics where it's mostly in the P3 area. So you want to drop the AP dimension, especially in P3. So there I like to do undersized and a complete ring in order to do that. And then the flexible I do because I've had a few cases where if there's any MAC or calcium, sometimes the valve can get pulled towards the MAC and make AI worse. So based upon those experiences, whenever there's any degree of aortic insufficiency to begin with, like mild AI, for instance, I'll put in a flexible. I don't have great data on that. That one's maybe anecdote. And same thing if I've got a highly left dominant circulation, I tend to use a flexible band just so I don't kink, just to have a rigid device that's going to pull in one direction and let it sort of conform more to the annulus.
Okay, Dr. Mick, comments?
Yeah, I basically use a flexible band on all degenerative pathology. I will use a complete rigid ring when there is a functional component, like atrial functional. Sometimes it's a mixed mechanism. So a patient who has maybe like a flail P2, but also long-standing AFib and a very dilated annulus. In that case, I would use a complete rigid ring because of the functional component. In my worldview, it boils down to, is there a functional component or not? If there's not, then I just use a flexible posterior band. For the tricuspid, the data is from Jose Navi at the Cleveland Clinic that the greatest durability of tricuspid valve repair is in the form of a partial rigid band, partial rigid ring.
Great.
Awesome. Thank you so much. This has been very informative, as Dr. Fitzgerald alluded to this side of the drapes and how you guys choose your rings, etc.
Don't forget a lot of it's anecdote though.
Yes. One thing that we wanted to make sure we had time to talk about today were complications, status post mitral valve repair. So the first one that actually did happen in the case that we talked about earlier was after coming off bypass, the hemos deteriorated. There started to be some lateral wall motion abnormalities. As Dr. Mick alluded to, there was a pre-op cath, so you know what the coronaries look like. So if you are concerned about an injury to the circ, how are you managing that in the operating room? Is that, I've heard different surgical opinions about go to the cath lab, just do the bypass now. What do you guys think about that, and how would you manage that if it happened intraoperatively?
Of course,
So
this never happens to Stephanie and I, right? We're just talking.
it's happened to me once in my whole career, but I will say that the spectrum of presentation of a circumflex injury is extremely wide. It can range from really not seeing much of anything at all in the operating room to seeing something on a post-op EKG, the patient's totally hemodynamically stable, to completely hemodynamically deranged, unable to come off bypass, etc. So it really depends on when you find out. In the case that you just mentioned, lateral wall abnormalities, suffering hemodynamically, you really don't have any choice except for to treat that as a circumflex injury. The board answer, there's two board answers. You can either just go ahead and graft it, or you can also take out the if as a surgeon, you typically know whether you've taken deep bites near the circumflex, and you're very careful when a patient is left dominant because the circumflex is bigger and it's easier to catch it. If you have a strong clinical suspicion as a surgeon, you can go back in, take out some sutures and check again. But the safest and easiest thing to do is just bypass. But I will just say it's not that easy to bypass a normal circumflex artery. They're not big like coronary artery disease. They're not rigid. They're harder to bypass. So it kind of all depends on how hemodynamically stable the patient is and when you find out. Like the one time this has ever happened to me in my whole career, the patient was completely 100% hemodynamically stable, had no wall motion abnormalities whatsoever. It was only the EKG that was raising our hackles, and she was left dominant. And when the resident called me, he's like, they're making a big deal about this EKG. And and the patient had also had like 5 beats of V fib in the operating room, which is very unusual after an uncomplicated surgery. And based on that, like 5 beats of VFib and the fact that she was left dominant, I said to the resident, we got to take the patient to the cath lab and take a look. And we were happy that we did, because they were able to fix it in the cath lab. I know I haven't really answered the scenario that you gave, but I'm trying to impress upon the audience that it is a very variable presentation. And your management a little bit depends on when you find out and how strong your index of suspicion is.
And Stephanie, would you, if it was minimally invasive and you recognize that it's an issue, would you convert to sternotomy and do a bypass? Or in that case, would you send them to the cath lab? Versus if it was an open procedure and you recognize it, would you just do the bypass? How do you decide what to do about it once you diagnose it?
Well, I think it would depend on the hemodynamic stability of the patient. I mean, if the patient is hemodynamically unstable, you have really no choice except for at that point to do something about it. If a patient is hemodynamically unstable, and I think I would probably go ahead and do a sternotomy and bypass it. But that's not usually how it presents. It's usually more of a vexing clinical picture than that.
Okay.
Dr. Feynman, I know you've had experiences where there has been circumflex injury. To Dr. Mick's point, can you talk a little bit about the clinical presentation and kind of what raises red flags in your mind that, hey, there might be an injury to the circumflex?
Sure. As she mentioned, I've seen a wide variety of clinical presentations. I've had the classic, we come off bypass and the lateral wall's not moving and we're struggling hemodynamically. And I think in those situations, you've got a pretty clear-cut explanation as to what's probably going on. I've also had cases where we come off bypass on, barely any support. EF looks great, no wall motion abnormalities, EF of 70%, bring them up to the unit, and then that evening they start to develop some kind of non-specific ST changes, start escalating their pressors. Eventually, that later that night or the next morning, they make it to the cath lab and they see that there is, a stitch through the circumflex. So I think that, given the variability in presentation and given the variability in coronary anatomy that we can see in our patients, if you have any significant wall motion abnormalities, whether it's something you would think of classically as being circ territory or something that's more, posterior apical, then you have to kind of keep that in the back of your mind as a definite possibility. Or if you're having kind of unexplained ST changes that aren't getting better, that you can't really explain by air and, moving its way through, then you have to consider that there may be a circumflex problem.
Dr. Atluri, let's say you do a tough mitral annular calcification, tough MAC case, you put in a bioprosthetic valve, you're getting ready, you're coming off, and you start to see blood come up from the back of the heart. So walk us through, for the benefit of something that's rare but potentially devastating. Walk us through how you approach that and what you want your anesthesiologist to tell you, and information, and how you approach that surgically.
Yeah, there's not much they're going to be able to tell me there, right? I think it's pretty clear. So at this point, we work together to make sure that we have stability, hemodynamic stability, and for that, you're going back on bypass, right? There's no way around it. You go back on bypass, you rest the heart, you got to take the valve out. And then at that point, you have to see where the hole is. You patch the posterior. One or two things, the calcium's really bad. Now you may be bound to take out that MAC. More than likely, you can just put a posterior patch in. Usually I use bovine pericardium. In a few instances, I've had to do it. And then you put the valve back in, and you try again. But you've got to take care of it. There's no way around it.
I think in that scenario, I want you to tell me if you're suspicious that this is going to be a problem before we separate from bypass. What does it look like in there? Especially if there was a lot of MAC, it'll be open and I can't see as well as when it is a minimally invasive approach. So when you have, usually it's the LOLs, the little old ladies, that this is a problem in, and it's hard to see. It's hard technically, it seems, for the surgeons. So I think it's nice when the surgeons alert us, this is an issue, and then we can discuss what our hemodynamic goals are, potentially including minimal inotropy to avoid stressing the AV groove.
Yeah, I think that's more important once we come back off. I mean, once you recognize it, once you go on bypass and you unload the heart, it's not as big of an issue. But this is a lot of lessons, same lessons we learn when we're doing TA TAVRs, right? I mean, protect that apex and make sure that your left ventricular end diastolic pressure is not high, that you drop your overall blood pressure. And so I use those same goals, really not just with an AV groove disruption, with any tough ventricle to deal with. Yeah, but quite honestly, at that point, once you recognize, you go back on bypass and you drop the LVEDP.
Okay. Dr. Mick, you've got a case and mitral stenosis. You end up replacing the valve, and when you come off, you've got pretty severe, not only pulmonary, you've got pretty severe RV dysfunction. How do you approach that? What are your thoughts in terms of how you manage that?
So you're going to want to talk carefully with Megan, and you start revving up the nitric and all of the inotropes and so forth, and see if you can come off. If you can't, you're going to be starting to think about coming out of the operating room on ECMO. I mean, when you say pretty significant, I assume you mean very significant RV dysfunction. Yeah. Typically, that's going to be from inadequate protection. So a lot of this is being very careful with your cardiac protection in cases like that to try to avoid this circumstance. But I think that's basically the quick and dirty, is that you support them as much as you can inotropically and with nitric. And if that doesn't fly, then you're going to be looking at ECMO.
Yeah, I think that makes sense. Dr. Fitzgerald, thoughts from medical optimization? Any other strategies prior to MCS?
I think just going back to your tried and true tenets of RV dysfunction, keep the ventricle as empty as you can. Don't volume overload. Give it inotropic support and vasodilation with nitric oxide, and then keep watching it. Just because you got it looking better doesn't mean you're out of the woods. And especially when the chest is closed, assess again, do a whole nother set of numbers and make sure everything looks good still. And there was a question in the chat about PA catheters, even for minimally invasive mitrals. And now that we're talking about all these complications, so our practice is to put PA catheters in all patients. I don't think there's a single patient that goes to the CT ICU without a swan. We're very comfortable with them. It's a very low risk procedure for our practice, and it can help you put the story together and make a diagnosis when you're having trouble with a patient that's has a confusing picture and a possible complication. So we love swans.
Dr. Feynman, can you talk a little bit about your experience? I know you mentioned it in the chat with PA catheters at Penn. I think the approach is slightly different than that at Cornell.
Sure. Yeah. I mean, historically, we were the same way. We put PA catheters in everybody, like in normal EF cabbages, PA catheter, minimally invasive mitral, PA catheter, everybody got PA catheters. We've moved away from that a little bit. I mean, we're still probably, towards the PA catheter end of the spectrum nationally. But for a lot of the minimally invasive mitrals, if they have normal cardiac function at a baseline, I'm talking, EF 60% or greater. If they have normal RV function, they don't have any other major valvular lesions that we know about. Then we'll place, a MAC line and a slick through the central port in the MAC, so that we have the ability to place a swan, at the end of the case or intraoperatively if we need it, if, things really take a turn. But we found that having the swan in place for some of these patients, if we don't extubate them in the operating room, would actually kind of delay extubation up in the ICU, because they're, some of the nurses were, trending numbers more than, necessarily total clinical picture. So in those patients who we think that we can extubate in the operating room and that we think are pretty low risk surgically, we'll avoid putting a PA catheter in.
Let me ask Dr. Lurie. I'm going to kind of
go ahead.
Sorry, I'm going to package two questions into one for you about left atrial appendage. So one question is, how do you technically do the clip from a minimally invasive approach to make sure that you're across the base and that you have it? And then second, related kind of is for those who choose to do an endocardial closure from the inside through a minimally invasive approach, that's probably the technique that's probably gotten the most probably discredit, like most criticism in terms of completeness or lack of completeness on TEE. So thoughts in terms of both how to do the clip and then if you're going to close it from the inside, how to make sure it's done properly.
Yeah, I mean, so how do I do it in an MIS setting? I use an endo balloon for about 90% of my cases. So with that, then I do it after I go on bypass, I go low flow. I've got these malleable retractors that I use that actually I developed for that we had custom made, but really you could use any thin malleable. I had them made for myectomies, but it's perfect because you have your system just sort of lift up on the aorta very gently. And then I put the MIS clip through the sinus and at what I think is the base. And this whole time I've got my cardiac anesthesia partner with the TE. And so put the clip on, but before I release it, I ask them to look on the TE and make sure that it appears like it's at the base. And if not, I adjust it. And once they're happy, I deploy it, take the malleable out and then reestablish full flow. Important thing to remember is you got to tell your assistant not to pull hard because there's all that soft tissue between the aortic root and the left atrium that is extremely friable. If you pull up too hard, you will have dark venous bleeding that can be very troublesome after the surgery. So that's what I do. I've stopped closing from the inside. I think there's enough data out there that the rates of recanalization are pretty high. The people that do it, I think, just tell you you're supposed to get really good endothelial apposition, but the problem is endothelium doesn't fuse to endothelium. So I've sort of given up on that approach.
Dr. Mitty,
You still oversew from the inside?
I've never oversewn from the inside.
Hmm.
I don't oversew from the inside because of the very, very high recanalization rates. I tend to use, when I do put the clip on with the robot, first of all, I'm going to be honest, it's really not so easy and it's a little bit hazardous because you are lifting way up on the aorta and you're pulling the left atrial appendage way close to you. You can't really see that well. It's quite, in my opinion, it can be quite hazardous. So up front, I tell people that I don't know for sure I'm going to be able to get a clip on. And in fact, that is another reason I won't do a robotic case. Like in a patient who has AFib and maybe has had a stroke from AFib, and my priority is to do an ablation and give them the benefit of a left atrial appendage exclusion, I will, in a case like that, tell them, hey, listen, I think we should just do a sternotomy and be certain that we're going to do this. If a patient has had like one episode of AFib in their whole life, and I'm going to do like a left-sided maze when I do their mitral valve, I'll say, listen, I can try to put the clip on, but I can't guarantee I'm going to do it. I mean, it becomes harder and harder to tell people that when with the LEOS 3 data and the profound effect on stroke risk overall. But when I do put a clip on with the robot, I tend to do it with a chitwood. I put it on after the aorta is clamped, go, empty out the heart, put it on, get it in there if I can, try to get it down to the base. And then I check it from the inside when I do the mitral valve repair. But I've said this at a lot of meetings and many people say, oh, it's so easy, you can do it all the time. I just don't agree with you. I don't think it's that easy. I think it can be quite hazardous.
No, you're right, Stephanie. And I think one point that is really important, which you alluded to, which is that people that have had longstanding AFib, many of them have actually had ablations. And sometimes there's scar that actually forms from the roof of the left atrium to like the PA or in that AP window area. And you just can't get through unless you're going to cause bleeding. And I've encountered that several times. So I think it's important what you said, which is you've got to let patients know that you may not be able to see it on all occasions. And sometimes the appendage is very lateral. It's really hard to pull it up. And guess what? If you tear it, and I've got a great video where I tore it with the robotic forceps.
Yeah.
And we only had one shot. At that point, you got to get the clip on, otherwise you're making a sternotomy. And we got it on. Hence, I saved that video. But
There's a question in the chat. What about directly placing a Watchman or occlusion device? That's an interesting thought.
my God, that's $30,000. My administrators would kill me. And considering I'm on
Let's
the supply chain now, I'm not sure I advocate for that one.
there are a couple of questions about Pavan, you come off and there's still, even in expert hands, there's still 1+ MR the first time you come off. So what do you want to know from Jared? And then what's your approach? How many times would you go back? You know, how do you approach this?
Mhm. Well, there's 1+ MR, but usually 1+ MR becomes 2 when you end up in the post-op setting when the patient's fully awake. So now I need to know, where is it coming from? What's my coaptation height between anterior and posterior leaflet? Is this SAM related, or is this still primary degenerative disease? If it is a degenerative valve, if it's annular dilatation, where exactly is it coming from, and what does the coaptation look like there? If it's functional, if it's a functional MR valve, I need to make a determination on, there's really not a lot of steps left. And at that point, do you have to replace the valve? And then with the degenerative valve, yes, we absolutely will try to repair. Oftentimes, thankfully, it's coming from an adjacent cleft that might have been missed. Sometimes it's related to SAM. And so I will tell you, my approach to that in the SAM setting is, can we medically treat through it? But more to see, is this truly SAM related? I don't love, I've gotten less aggressive with the whole volume loading, beta blocking, stopping inotropes. Because I remember, Stephanie, do you remember a couple of years ago at the Mitral Conclave, David talked about a case of his where patient showed up and had SAM and was still short of breath. And the only way they could provoke it was the stress echo. Well, I've had one of those cases too. And so I don't, especially young active people, I don't like leaving, a narrow LVOT with even this chordal SAM stuff, because I think it'll compromise long-term outcomes and result in long-term symptoms. Yeah, so that's the big stuff there, right? If you've got a really small height of coaptation, you've already put a small ring in, then you may be bound to a replacement. I think one thing that I learned, and I love something that Kevin Akala says a lot, which is he says, I can repair any valve, but I can't have all valves last. Meaning, some valves just can't be repaired long term. And I think there's humility that needs to come when we encounter those valves, to say, this valve may not last 10 or 15 years like we try getting our bioprosthetic valves to last even.
Right.
So
let me take two, Pavan, let me take two questions off the chat and direct them to Stephanie. So one is mitral repair in the setting of mitral valve endocarditis. And the second is somebody who had a previous mitral repair, can you re-repair that? So if you wouldn't mind, Dr. Mick, taking kind of both of this in conjunction in your approaches.
Sure. So mitral valve repair in the setting of endocarditis is the goal. But the major goal is to get out all of the infected tissue. So the principle is, you go in, you take out what's infected, you get down to healthy tissue. If you're then left with enough tissue to put back together again reliably, then great, repair it. And that can be with patches, that can be with cords, that can be with, whatever you do normally to repair valves. But the goal is repair. But the goal is actually, the major goal is to remove all infected tissue. The next most important goal is repair. And if you can't repair it, you have to replace it. And then the second question was previous repair.
Yeah.
So previous repairs can certainly be re-repaired, but it really depends on the fact that the previous repair was inadequate. So there's several ways a repair valve can fail. In my experience, the most common repaired valve I see is a repaired valve like 15 to 20 years down the line that was a resectional repair, and now the entire resection plane has become fibrotic and scarred, and the posterior leaflet is restricted. That's not a repairable valve, because there's the whole point of mitral valve repair is taking redundant tissue and making it less redundant, and in broad strokes. The times, it's certainly possible to re-repair failed repairs, and it usually amounts to the first repair not being adequate and then it failing within a year or two. But certainly there's a lot of good data out there to suggest that re-repair is safe and durable, as long as there's an obvious thing that needs to be done.
Okay. Dr. Fitzgerald, there's a question in the chat about neuromonitoring and NIRS. Is that standard for you from at your center? And then Dr. Feynman, how about in Philadelphia?
In minimally invasive, we use cerebral saturation monitoring in addition to the bilateral upper extremity art lines, so that we can sense balloon migration. And all comers will use it in patients with any neurovascular disease. And we don't do it universally for all of our cases.
Similarly, we use cerebral oximetry for all of our pump cases, including minimally invasive. We also use the bilateral A lines for balloon migration. We don't do anything like EEG or something that we would do in some of our more complicated CIRC-RS cases in the way of real deal neuromonitoring.
Before we only have a couple minutes left, and I want to get to one last complication. But before we do, we're just gonna ask everyone to answer the poll question. Just can we get a little more demographic data about who joined us tonight? We're very excited about that. One thing for Dr. Fitzgerald, you're doing your post-op exam and you noticed some new aortic regurgitation. That wasn't there preoperatively, there was none, now there's some. What are you worried about with this new aortic regurgitation? Are there certain things about the jet of aortic regurgitation that makes you more concerned, less concerned? And what are you communicating to Dr. Mick at that point in the operation?
I think the biggest concern would be whether or not the mitral intervention impacted the cusp of the aortic valve leaflet. And so I think that the direction of the jet will help elucidate that. And then the degree, I'll try to quantify it as much as possible to see if we can attempt to manage it or can expect it to have hemodynamic consequences.
Great. I have one question to Dr. Mick and then to Dr. Atluri about just mitral repair itself. So there's a recent publication from Dr. Gammey's group looking at Medicare beneficiaries and mitral repair rates. Less than 5% of mitral valve surgeons, less than 5% of surgeons who do mitral valve surgery are able to repair greater than 90% of mitral valves. So that's a very high threshold. Both of you are very prolific mitral valve surgeons. For surgeons who are in that 50 to 60% range of repair, or they're earlier in their career, what's your advice on how to navigate that journey so that they can, so surgeons can aspire to try to hit that benchmark? Stephanie first, and then Pavan.
So you're saying an early career surgeon who's repairing 50% of the valves, how can they repair more valves?
In general, just surgeons in general, how to out of training, how do you get to a point where you're repairing, hitting that mark?
I would say that if you don't feel capable of repairing a valve by yourself, if you're an early career surgeon, you should be involving a senior surgeon in the case. You should be watching as many repairs as you can. You should be going to mitral conclave and like meetings. We have a mitral valve repair course coming up at the STS that you could come to that. I think that if you are in that camp of surgeon and you don't feel capable of repairing a valve, then that might be some time for some humility and not replacing a valve because you don't know how. I think it's just all about self-education.
Pavan, your thoughts?
You're muted, Pavan.
You know, I've thought about a lot about this. I actually wrote the editorial for Jim's paper, JTCVS, and it's a topic that I think we struggle with in our field quite heavily. I think it starts with a good foundation. You've got to be very comfortable with the valve, and I think often that will come through residency training or specialty fellowship training. And the question really is there's only so many centers out there that do a lot of a high volume of mitral valve repairs in order to be able to afford their fellows that or their residents that training. If not, I think we need to figure out how to get more centers out there that can train people. I actually think we need, you know, potentially the senior surgeons who would do a lot of volume to take some time and mentor junior faculty member at both their institution. I love Stephanie's idea. And similarly, I've told any one of my partners that if they have any problems, I'm happy to come into the operating room. You don't have to put me in the op note. You don't have to tell you're referring, but let's get the valve repaired. I think that helps. But we need to figure out how to get more broadly out into the community and help all these other surgeons. You know, that GAMI paper, it's astonishing because the average surgeon does 3 mitral valves a year. It's 2 repairs, 1 replacement. That's a very small number of cases to do on a regular basis and have any expertise. So then it comes down to, all right, well, then do you consolidate? I'm not even sure you can consolidate to cross that volume outcomes curve, right, and hit that inflection point, which is, I think, probably in the 30s for most procedures that we look at. I know I'm going in circles a little bit, Shuba, because I don't have a perfect answer for you. I mean, we're only doing 16,000 mitral valve repairs a year, and then you split it by the number of open heart centers that we have. The math just doesn't add up for everybody to be able to do mitral valve repair.
Right. And with that, I think this is a great place to stop. On behalf of the STS and the SCA, we'd like to thank Dr. Pavanat Luri, Dr. Jared Feynman, Dr. Stephanie Mick, and Dr. Megan Fitzgerald. On behalf of my co-moderators, Dr. Gina Lingana and Dr. Avinash D'Souza, thank you for joining us. Please fill out any of the surveys, and we'll see you in a couple months for our next session.
And we'll just have a few announcements from STS and SCA. Thank you, guys.
Thank you so much. On behalf of STS and SCA, thank you to all our SCA and STA moderators and panelists for your participation and insight. Stay tuned for the next installment of Across the Drapes coming in February 2026. Speaking of 2026, if you'd like to become a member of STS, we invite you to use the QR code. You'll enjoy a variety of discounts and benefits and opportunities to help you grow professionally. Learn more at sts.org/membership. And please register. It's now open for STS 2026. Use the QR code and find out more at sts.org. And lastly, SCA has some great opportunities ahead as well. You can stay connected with SCA using the QR code as well. So thank you so much, everybody, and have a wonderful night.
Great. Thanks, everybody.